button. And I am very excited to welcome Dr. William Mansbach and Heather English from CounterPoint, who played a very important role in setting this discussion up today. So I'm going to stop sharing my screen, and hopefully Dr. Mansbach and there's Heather can come to the stage. But Heather, I'm glad you popped on first because I'm going to pick on you first.
Good.
You're the reason that we're having this discussion because you were on one of our discussions a few months ago, and I learned about what CounterPoint, your organization, does. And I swear, I think I called you and 3 times in the next 3 weeks, and because I was getting these questions from folks that said, I think my loved one might have dementia. What can I do next? And your organization is very unique in the solutions that you offer, and you were very helpful to those individuals. And I said, hey, we've got to have a discussion around this question. But which is why Dr. Mansbach is here. But Heather, before we
Yeah.
bring on Dr. Mansbach, who's part of your organization, tell us a little bit about yourself and what CounterPoint does. But and also for everybody, Heather is in a nursing home right now, which is why
Yeah.
she's got her mask on. So
Steve, thank you. Thank you so much. And thank you everybody for joining us today. I apologize for the mask or whatever, everything that's going on. It's just the way it needs to be right now. But I appreciate the introduction and having everybody join us today. So one of the things I think that we found, as Steve said, especially even coming out of the pandemic, that there are a lot of families that are noticing loved ones that may have dementia, not sure. To some of us, it might be a 101 and we really understand it, but we also understand there's so many questions out there and many people don't know where to go. So that's one thing. Dr. Mansbach is going to share some really great resources that we have and a little bit about CounterPoint. So my title is Director of Market Development, but my role with CounterPoint is I really act as a liaison and a source of, I guess my passion is really to help as many people that we can kind of understand the process. We have great resources that we can share with you all as well. We do go into communities such as nursing homes, assisted livings. We are soon to be starting in some adult daycares, which is really exciting. We're hearing there's a big need as well there. We definitely specialize in dementia. The Bcat is our research center. So I have learned to say the aging population because we are seeing many younger folks dealing with memory loss, and they're not sure if it's dementia or if it's just normal memory loss. So we're big on the brain health, psychiatry, mental health overall. And at this time, I will hand it over to Dr. Mansbach, and thank you all for joining us today.
all right, Heather, and before you leave, just make sure you drop your contact info into chat, and that way folks can get in touch with you. So, Dr. Mansbach, I'm again very excited to have you as a featured speaker today. The let's see, let me get there. Okay. You're always very popular with our audience and a wealth of knowledge. But before we dive into sort of addressing, I think my loved one might have dementia, tell folks a little bit about your background and what led you to the current role that you are in now.
Well, sure. And first, thank you, Steve, for having me back. It's always good to be able to have a conversation with you and have an audience that hopefully we can support and inform. Heather's great. I've been working with Heather for many years through many companies. She's just a terrific resource. And as you can tell, this is really her passion. So comes through very clearly. My background is in geriatric neuropsychology, actually, both as a researcher and as a clinician and as a business operator. I've been doing this work for a long time. And so, like with Heather, my passion is to try to provide support not only to the patients we evaluate and care for, but really their families. I mean, we spend a lot of time trying to educate and support families who really struggle. Heather had referenced the COVID-19 pandemic, and certainly that's made things much worse in so many ways. But I think the sense of isolation that so many people feel, whether they're in the community, whether they're in senior living or a nursing home, is quite real. So I do a lot of research, I do a lot of clinical work, I write a lot, and fortunately, I have an opportunity to speak with people like you, Steve. So I'm happy to be here, and for the audience, really, this is an opportunity to ask any question that you think would be important, either for you or for a loved one. I'm happy to answer.
Well, and why don't I just we're going to dive into this, but why don't we just kick it off, because the question has already come in, and this is a great way for our audience to see how interactive these discussions can be. And someone says, what would be a good way to begin the conversation with a parent you feel may be in the early stages of dementia? They don't think something is wrong, but the family is unable to get them to maybe talk to somebody. And this, you have the ability to ask questions anonymous. This was an anonymous question. And I want to thank whoever asked this question, because this is the reason we're having this discussion. This question, or one similar like this, I think I get them at least once a week, if not every other day. And what are your suggestions to a family or an individual like this?
Well, not only is it a great question, Steve, it's a ubiquitous question. We get this question many times every day among our providership. So I'm happy to begin to address it. The idea that perhaps one has Alzheimer's disease or related dementia, or even significant cognitive decline that might result in giving up a home or giving up maybe the keys to a car. A dramatic change in life it's a terrifying idea. And it's very challenging for a loved one to begin to have this conversation when she or he observes that there are real changes. So the first thing I would say is that you're not alone. And if you feel alone, it's important to first broaden the team. What I mean by that is you can't always be the one that has the conversation with mom or dad or with a sibling. So sometimes you need to empower someone else. That could be first having a conversation with maybe mom's primary care physician or a friend or another loved one. It might be a good idea before you have that conversation to make sure you talk with other family members, get a sense of it's just not all you in some ways. So I would say that resistance from a family member is common probably half the time. But it comes from the right place. It comes from the fear of what really could be going on in some way. And when we talk about some kind of home self-assessments, I can talk a little bit more to what that issue really is about.
Muting myself. I type furiously through these discussions, and I've been told that people can sometimes hear my keyboard. That's why it took me a while.
Sure.
And actually, I've got both the CounterPoint and the Bcat websites loaded up. So if you start referencing pages on your site, I can drop those into chat. But this is, one of the things that over the years that you hear experts talk about, and this is why when people call me and they wonder about dementia, you often hear that it's sort of, well, how many medications is your loved one on? How isolated are they? Because these types of things can manifest themselves as dementia. And I guess, before somebody starts shopping around for a memory care community for their loved one, is there such thing as like an MRI that you can, say, okay, mom definitely has dementia. She's ready to go. What are some of the steps that can give people peace of mind that mom really has dementia or Alzheimer's?
So to unpack your question, I think that there are two sort of main components to it, Steve. The first is it the case that other factors can make one cloudy in terms of thinking, make one less efficient in terms of memory, less capable to organize their life? And the answer is yes, it can be too much medication. It can be infections. There's actually a technical term for all this, which is really a noise inefficiency in memory. It's called NOM. So one of the things that we do as professionals, we first try to rule out, well, what might be contributing to this that has nothing to do with dementia? What really could be going on here? And there are a number of questions. And certainly talking with primary care is important, because that's usually the primary clinician who is overseeing things like medications, infections, and things of that sort. So the first part of that question is, yes, there are these factors. The second is there really kind of a litmus test, right? Does mom have dementia? Does mom have a pre-dementia syndrome? We refer to it as MCI, or mild cognitive impairment. And are there reliable assessments that can be done both by memory experts such as myself, or by family members, or a loved one, an older adult perhaps, who's really worried? And the answer is yes. So Steve, if this is a good time, I'd like to take people through a reasonable progression of moving forward that's not a heavy lift, that gives people some resources to consider.
I love it. And I think this is we've got a bunch of questions coming in, but I think this may answer some of them and create more questions. Okay. So yeah, walk us through this.
So in the chat, maybe you can put this resource. It's www.enrichvisits.com. And the reason for that is we did some work with an advocacy group a few years ago called Us Against Alzheimer's. I'm sure many people in the audience have heard of them. They're a group much like the Alzheimer's Association or the Alzheimer's Foundation, one of these large groups that really try to support the older adult and their family. And one of the projects that we did with them was to try to identify when people begin to observe, either self-observe, or when families begin to observe changes in cognition, particularly memory. And what's the gap, Steve, between when people observe that there may be issues and when they actually talk about them to, let's say, their doctor or their primary care physician? So in the literature, it's about 2 to 4 years. And actually, that was our experience with this group too. What that really means is that a person could be experiencing the beginnings of a process like Alzheimer's disease, which is progressive, 2 to 4 years before they talk to their provider or the healthcare community. And as you know, the longer you wait, the harder it is to make an intervention. And in fact, if you wait too long, being able to stay in an independent living situation becomes at jeopardy, right? So we created a tool. It's free, anyone can do it, and it's on that website, and it's called My Mem Check, and it's actually used quite a bit in primary care now. So My Mem Check's pretty cool in the sense that you can do it. In fact, if you go up to the banner at the top, you can click on it. So My Mem Check was designed to be able to, in the privacy of one's home, at no cost, be able to identify if you really need to have some sort of evaluation in some ways. It takes about 2 minutes to do. You get a report, which will tell you a little bit about your memory functioning. It's not a diagnostic tool. You wouldn't diagnose someone with, let's say, Alzheimer's disease based on My Mem Check. But you get an actual report. So that report can be sent to another family member. It could be sent to primary care physician, anyone you basically want to. And what we found was that when we did a study with about 1,500 older adults, they really liked it because of the privacy. It got them going. It's a non-alarmist sort of tool. But it also then informed their doctors to begin to have a conversation, particularly for older adults who felt like their physicians weren't really hearing their concerns in some way. So step number 1 is to do My Mem Check. Anyone can do that. You can then have a formal conversation with a primary care physician, for example, or another healthcare provider. And based on that, you could then go see a specialist. Now, specialists are very hard to get into these days. So there are 2 options that you could do if you're having trouble. One is you can have a very good sort of the the state-of-the-art test called the Bcat that could be administered by a healthcare provider. It's done 2 million times a year. And if you wanted to do that virtually, you could do that through CounterPoint. Or through that Enrich Visits website that that you showed just a moment ago. Or you could have a telehealth or an actual in-person evaluation at CounterPoint if you wanted to do that. So CounterPoint is available as a resource, but I don't want the audience to think that it's the only resource. There are other providers that are out there who could be helpful, but start at home. Start with the privacy of being at home. Get an actual report from a validated test. So it's important that if you're going to do a self-assessment for memory or cognition, that there's very good science. And my MEMCHIC has that, and of course the Bcat has that. So let me pause there because I'm sure that there are going to be questions, and I'd be happy to address any of them.
Yeah, this is great, and I'm trying to drop these links in for everybody for not only now but for after the discussion. But okay, well, you actually addressed something that another question came in. It says one thing I found is that it's hard as a caregiver. It's hard as a caregiver if you see a neurologist for follow-up. And so you had mentioned that it may be difficult to get into a specialist, but having some documented result when you pick up the phone and call, or working potentially, does Bcat have neurologists and psychiatrists that are in your network?
Right. So just so people aren't confused, Bcat is a research center that develops tests like the Bcat, like my MEMCHIC and so forth. CounterPoint is a group of doctors and providers who actually take care of patients. There are providers all over the world who use Bcat tools. So you could see somebody who's using the Bcat, and that would be fine. So we are connected to lots of the healthcare community, and certainly in the DMV area, but in other areas, I think as well. One precautionary tale, though, that I think some of your audience will relate to is that there are circumstances when you might go, maybe you're a caregiver, an adult child caregiver, and you go with mom to see a physician, and there are some circumstances where the physician may not quite be taking the feedback as seriously as you think that it should be. I'm not saying that happens all the time. There are wonderful physicians who are out there, but it does happen. Doing something like my MEMCHIC brings credibility because now you have a validated, albeit self-assessment, but the physician has a starting point. They can say, oh, that's important. Secondly, not all primary care physicians and other healthcare providers, including neurologists, are going to use validated cognitive tests. So it is important at some point that a person receive a test that has, again, good science that can indicate if there is a problem, but also, Steve, what do I do about it? It's not like we can just prescribe kind of world-beating medications. There are other non-pharmacologic treatments that are really important that can make a difference in how independent one can live.
Great. Okay, we got a ton of questions here, and I've noticed a few in chat because they're hard to keep my eye on. I'm going to address Judith. Actually, I think Judith Byron has a few here. First, she says, how does one separate simple aging from problem aging? And then she also says, I understand hospitals offer memory care evaluations. Is this so?
So let me do the second question first, and then the first question second. I think that there are hospitals that have associated or affiliated with them memory clinics. And if that's the case, then I think they'll probably do that. It's kind of a caveat emptor situation. All I mean by that is call first and find out what you're going to get. Are you going to get an MRI, which, by the way, is probably not a good starting point. That might confirm a diagnosis, but you don't start with an MRI. Even if it indicates a problem, it doesn't tell you what to do with it. So that's going to be important. What kinds of tests do they actually do? So it's important to kind of do your homework first. Just because they have a clinic doesn't mean it's going to be helpful for you. So that's number one. Secondly, in fact, remind me what the first part of that question was. Speaking of memory, I want to make sure that I answer it exactly.
The first part of the question was how do you separate simple aging from problem aging? And again, I'm not picking on we're all aging, remember. It doesn't start at a certain age. It starts at birth. But we all get this question on a regular basis. It's and dementia and cognitive impairment is what I think most people refer to as problem aging.
Sure. So there's a difference between normal forgetfulness and a true memory disorder. As we age, we do become more forgetful, and that's because our brain becomes a little less inefficient over time. I could explain the neurophysiology to that if you'd like, but I think the takeaway is those neurons, and we have between 80 and 100 billion of them, become less efficient in how they're connected to one another around a memory or other kind of task. So one way of thinking about it is that if you cue someone, so Steve, let's say that I asked you a certain question and you didn't really remember what it was, what the answer was, but I gave you 3 possible responses. Then you said, oh yeah, it's A, or it's B, or it's C. Basically, it means that the memory got encoded. You just couldn't really find it. And that's an inefficiency. With a true memory disorder, though, it doesn't get up there, it doesn't get encoded in the first place. And the only really good way of determining that is through a cognitive test like the Bcat. I will tell you that we did a CMS, a Medicare funded study several years ago. And one of the questions was, how good are healthcare providers at identifying cognitive problems without using a standardized test? And the truth of the matter is no one was very good at that. No one actually exceeded 50% accuracy. So we had physicians, we had nurses, we had rehab therapists, we had lots of different people. So we might think that we can tell, but we can't really tell without having a good cognitive test.
Wow, no, that's very important for everybody in the audience to understand that. Okay, let's jump back on these questions. My mother was diagnosed with vascular dementia last year. I have had multiple concussions in the past few years. When I forget something, I'm scared I will end up like my mother. Also, her sister died with Alzheimer's. I'm 63 years old. What can I do to reduce the risk?
Okay, so 3 aspects of that question probably that should be addressed. But one is having concussions over time, particularly multiple concussions, usually does not, let me just emphasize that, but can contribute to some cognitive decline, but that doesn't mean that it will. But it does not lead to vascular dementia. That's a very specific course in some ways. So that's number 1. Number 2, the question, and I think it's the second most asked question that I get when I give talks to family members is, okay, so my mom's been diagnosed with Alzheimer's disease or related dementia. What does that mean in terms of my risk factor? And the truth of the matter is that all things being equal, 65 to 105, you have about an 11% chance over time of developing dementia. Of course, that increases with each decade or each 5-year increment of time. But if you have a parent, so it's the next generation, it increases as much as 1.5 to 2x or twice as much. So it could go up to 22%. But there are things that you could do, and there are many things that you can do. The Enrich website, Enrich it's an acronym. It stands for 6 modifiable behaviors that lower dementia risk. And this has been very much substantiated by quite a lot of research. There are more things, more than just these 6, but these 6 are most important. Again, you can do this at no cost. Go take the Enrich calculator, which will tell you how you're doing. The 6 things, they won't surprise you. A certain amount of physical exercise, that's the E. N is no smoking. R, which is the trickiest one, is routinely adding cognitively stimulating activities, and they should be working memory exercises, which I'll come back to. The I in Enrich is for improving mood. There's actually a link between chronic depression and dementia. It doesn't mean it will happen. It just means it's a risk factor. Treatment is important because that mitigates risk. C is controlling heart rate, blood pressure, and H is healthy weight to lower the risk of type 2 diabetes. If you're 50 years old and you're diagnosed with type 2 diabetes, by the time you're 75, you would be 5 times more likely to develop symptoms of dementia than someone who doesn't have type 2 diabetes. So, it is important that you know kind of where you are and what you're doing. And with respect to that R, that routinely adding cognitively stimulating or stimulating cognitive exercises, the best science in the world supports working memory exercises. And if you want a resource for that, you can Google the Bcat Working Memory Exercise book. I will tell you that in all fairness, there are other tools that are out there. Our study, our research really substantiates these exercises. That's why they're in there. They all went through research protocols and they're used very widely by professionals too. There's a home edition for people, who aren't professionals to do these exercises. Whatever you do, just ask the question, is there any science behind them? Because you don't want to do things that, sure, they could be fun, but you want them to promote neuroplasticity in the brain.
Okay, great. Again, for the audience, I am trying to drop in these links that you're referring as quickly as I can. Okay. Eileen Wilkinson says, is a NeuroQuant scan a respected tool in the mental health field?
So this is a tricky question. Let me answer it in this way, which is when you get to the point of imaging, I'll take it to that level. Imaging, traditionally you have CT scans, you have MRIs, you have fMRIs, you have SPECT, you have PET, you have all kinds of things. The preponderance of evidence is that CTs are not very helpful. MRIs and fMRIs can be quite helpful, and they're probably the standard. The PET scans in particular, which are quite effective, are very expensive and probably not where most people should actually begin. But let me try to clarify something for your audience, Steve, which is these scans, whether they're looking at structural changes or metabolic activity, they don't always translate to function. You can have what are called neuritic plaques or neurofibrillary tangles, indicators, let's say, of Alzheimer's disease, and not be very symptomatic. You can be very symptomatic and not have a lot of these tangles and plaques. So you can't get too excited, too agitated. You always, at the end of the day, have to look at function. Am I able to remember to take my medications, regardless of what a scan says, right? Can I make a medical appointment myself? What kinds of assistance do I need? And please, if I can emphasize this, there is no shame in getting help that will allow you to live as independently as you possibly can.
Okay. All right. Let's see. We've got a long question, but it's a good one here, and I'll do my best to paraphrase. But it says, I found it to be hard. Is you see a neurologist for follow-up for Alzheimer's, but may also be dealing with depression and anxiety for their entire life. So you see a psychiatrist for that. And then you have your primary care physician for other things as a caregiver. It's hard to figure out who to go to and what's impacted by Alzheimer's and what needs dealing with other things. Man.
Right. So lots of cooks in the kitchen, problems emerge. Where do you go? Plus, there's an overlap. So you can see a neurologist who perhaps is prescribing what's called a nootropic or a memory enhancer, but could also prescribe, let's say, an antidepressant. Yet you could see a psychiatrist who could do all those things too. And of course, so could the primary care physician who has the body of knowledge to inform you. So I think about this question in two ways, because the communication is also an issue, making sure that people are talking to one another. So the burden isn't on the patient. I mean, why should a patient have to be communicating, well, the neurologist said this to the psychiatrist and so forth. So a shout out to care managers. Sometimes when things get overwhelming, getting a care manager, geriatric care manager, who really can run point for you can be enormously helpful. And there are many of them. Steve, you know many of them. Many of them are part of the pro-aging network. We work with them all the time, and fortunately so, because we're on that doctor end. So we don't want to be part of the problem. So that's one idea. The second really is try to simplify. I mean, I think that the treatments that you do for, let's say a disease like Alzheimer's disease, medications are really limited. However, medication treatment for depression, it's much more expansive. There are far more things that you can do. It's just complicated to know, well, if I take a medication, a sedating antidepressant so I can sleep, is that going to make my memory worse? So I try to make things a little bit more simple if you can, and having someone interpret the stuff like a care manager can be really, really helpful.
Great. And I know we've got a few care managers and representatives in the audience. I am dropping their contact information in there for anybody that would like to reach out to those resources and learn more. Okay. Let's see. Okay. Jose says, what about gerotranscendence? How do you distinguish normal aging with memory loss versus ADRD? And do you know what he's talking about? And can you give us okay.
So let me first say, let me try to address this complicated and quite good question in this way. You know, you're out there, you're concerned about a problem, you're trying to understand, is it real? Does it have one singular cause when there could be many different causes? And you're bombarded by an industry that says, well, do this, or try this scan, or do this intervention. You know, does a person have some sort of attentional disorder? Does someone have a primary dementia? Is this caused by sort of mood in some way? So I think before we really rush to an alternative treatment, let's first try to figure out from a basic approach what might be wrong. So let me give you a very concrete example. So at our place, what we try to do is we try to evaluate a person and break down what is essentially cognitive, what is essentially mood, what might be essentially behavioral. So we try to identify these in sort of these three spheres. And then we try to figure out, well, what could be causal in some way? So we take a very careful history, a personal history, a medical history, psychiatric history. If we don't have an answer after that, then we go to some of these other alternatives in some ways. But I get worried when people say, well, what about this kind of alternative when we haven't kind of gone through the basic routines first.
Great. Okay. Lindsay Vajpai from Insight Memory Care has a few great questions that are going to help us understand these resources that you've developed. And the first is, what is the Bcat assessment process like?
Yeah. So the Bcat, so if you think about Bcat as a way of thinking, right, not just a tool, Bcat really is about, it starts with this idea that cognition is a vital sign for basically all of us. In medicine, we don't usually think about it that way, but it is. It is a vital sign. And so it must be measured like every vital sign. If you're concerned about blood pressure, don't you measure blood pressure? You have a blood pressure cuff, you have systolic, you have diastolic, and so forth. So in 2006, we developed the first Bcat test, and the idea was, can we make available to any kind of provider, not just memory specialists, a way of assessing that vital sign? And to do that, it has to not just say, well, do you have probable dementia or probable MCI or normal cognition? It should really tell us specifically about memory, about what are called executive functions, about attention, and something that we call the cognitive task manager, which is a way of predicting, can I live independently? And what do I need to do in order to live as independently as possible in some way? So function is really a really important aspect of all this. So there are actually 6 different kinds of Bcat tests, but the foundational Bcat, which most people think of as about a 15-minute test that with very high sensitivity, about 96%, would identify, do I have dementia? Do I have MCI? Do I have normal cognition? It'll tell you about memory capacity, about executive capacity, about attentional capacity, and about your independent living capability. So very strong science. It's used very widely in every setting. It doesn't have an education bias, doesn't have a race bias, but it has to be administered by a healthcare professional who's licensed to do it.
Okay, so that leads into Lindsay's second question is, what qualifications would a professional need to have to administer the Bcat?
So licensed professional in almost any field, you actually can do all your training online. I mean, it doesn't take very long. It's a series of videos for each Bcat component. We tried to make it very simple. So there are one-off clinicians anywhere in the United States and in other states that do the Bcat. They sign up, they get it, and so forth. There are large companies in healthcare that use Bcat. So it's used in hospitals, it's used in nursing homes, it's used in community practice, it's used in lots of different places. But you can do it all online. And if you have any question about Bcat, info@thebcat.com. You'll be answered within 24 hours from someone from the team. We get these questions. Some of them are research questions from Portugal. Some of them are clinical questions from providers. Some are just family questions who say, so-and-so administered a Bcat, what do I do now?
Okay, great. And her last question, these are great, Lindsay. How is the Bcat different from neuropsychological testing?
Yeah, so neuropsychological testing is usually a series of battery of tests. It takes usually a number of hours to do. The Bcat is a condensed version of this. When we did our first protocol in 2007, I think it was 2008, at one of our memory clinics, we had the neuropsychologists administer independently their 3-hour battery, whatever it was. We had other clinicians administer the Bcat, and we found that the Bcat in 15 minutes explained, and this is going to sound technical, 95% of the variance of the neuropsych battery. All that really means is that diagnostically, it could tell you what the neuropsychologist did in 15 to 20 minutes rather than a long battery. Now, it doesn't have all the details. Look, I like neuropsych batteries. I mean, I do them. But the Bcat is really the beginning place, and it's much more efficient, I have to say.
Great. Okay, Betty's got a very interesting question here. She says, I've heard many examples of people with cognitively demanding jobs having cognitive decline when they quit performing those mental tasks involved in their jobs. Is there a connection between cognitive decline and retirement?
There is, but it's modulated by mood more than anything else. So what's really important is that when you look at changes in cognition, you have to look at changes in mood. Also, the brain has to recalibrate. Think about it. The brain is used to a certain level of activity of all these neurotransmitters that are being activated. Neurons are receiving them. We're continually making new connections all the time among all these neurons. When we stop doing that, it's all of a sudden a hard stop. It takes our bodies and our minds a while to adjust. I always say you start pre-retirement at least 2 years before you actually retire, which means that when you retire, you should be planning for how to keep my brain active, how to keep my body active. You've heard me say this before, Steve. You want to move your body, you want to move your mind, and you want to move toward other people. In other words, be engaged with other people. So I don't think that just going from an active job to an inactive retirement or a retirement doing different kinds of things causes dementia. It's a change in how the brain functions.
Yeah, and I think I like how you frame that, because this is one of those things that can get camouflaged. If somebody doesn't have purpose and they're not, they may show some signs that, boy, dad's different now, it's having a more defined purpose every morning when you wake up. Um, let's see. Question. It says, is there a correlation between ADHD and the risk of dementia since both affect working memory?
Yeah, I love this question. And in fact, we just did a master class in Bcat. So this is a class that people who use the Bcat can be invited or can invite themselves in some ways. So we talked a little bit about the role of attention in making new memories and so forth. So there's a very slight, and it is slight, enhanced risk factor if you have ADD or ADHD and developing dementia. What really happens, though, is that the attentional processes soften anyway over time. So I think what happens is that the acceleration of change is a little bit greater because of just difficulty in attending and focusing in the first place. So she's right about the connection with working memory, but it also indicates why it's important to do working memory skills or activities, especially if you have ADHD or ADD. So don't worry that you're going to develop it or someone's going to develop dementia because of it, but take that as an opportunity to really work on working memory.
Okay, great. And then let's see, William says, are there resources to determine if most Medicare healthcare insurance companies cover the BCAT tests? How about long-term healthcare insurance?
Yeah. So what happens is it's not that there's a what's called a CPT code or a billable medical code that's assigned to BCAT. It just means that if you're a provider, you can use the BCAT and it's sanctioned as Medicare will pay for that particular service. So from a Medicare or a payer standpoint, it's not a problem at all. The issue of long-term care insurance is really, it's a fascinating one because that's an industry that's really changing. Maybe there are some people in your audience right now who know that better than I, probably so. I don't know of insurance companies that where all of them use it, but I know that some of them actually do. And I don't know the ins and outs of that industry very well.
Yeah, and I am going to drop in to chat our discussion from last week on long-term care insurance because it was fascinating and there's some really good info in it. So I'll drop that in here. But Martha says, are there any exercises or assessment questions available in languages other than English?
Yeah. So first of all, from an assessment standpoint, you can have BCAT in different languages. Spanish is an example. So I think the assessment part is not particularly difficult. I remember in Howard County, Maryland, some years ago, when the BCAT was not just translated, but validated in Korean. That's a very complicated process. And in fact, so there's a difference between translation and validation. If something's translated, it just means that it's in another language, but it doesn't mean that it's culturally valid. So I'll give you an example. Those of you who do the BCAT know that there's this story recall item. It's very important in this case. One of the versions is there's a woman, who borrows $10 from her brother and so forth. And she spends the money on an ice cream cone at the circus. Well, you have to make sure that a circus actually makes sense in another culture. So we took that very seriously at the BCAT. The more complicated part, though, are there, let's say, working memories and other exercises in other languages, and there just aren't really the kind of, it's just not resource dense or rich, Steve. So even at our place, we don't have working memory exercises in multiple languages, although I think we likely will.
Okay, great. Well, okay, let's see. If Eileen asks, and I think we're winding to the top of the hour, but also to the end of the questions here, so that always triggers people to ask a few more. But Eileen says, is anyone at BCAT researching the advantage of art-specific activities for working memory?
Yeah, so if I heard you correctly, art. So
Art,
we've
yeah.
actually we've done projects in this, and in fact, Some of it's been just working with art, and there are groups. There's one in Montgomery County, for example, really important in working with people with dementia, going to museums even, and things of that sort. So yeah, we've done some work in that. We've also done a lot of work with CMS that resulted in the MEMPICS program, which is not so much work, but pictures and how you use actually visual imagery to lower agitation in dementia. MEMPICS is, maybe some of you are familiar with that. Caregivers use MEMPIC books to engage and communicate with a loved one with dementia quite frequently. So it's a wonderful question. I 100% believe that art is an underutilized resource and actually asset. So thank you for asking that question.
Great. All right. Well, here it happened. I knew it was going to happen. Okay. Is there any research on PTSD and the connection with Alzheimer's?
Yeah, so there is. So to be really sort of concise about it, Steve, it's not that post-traumatic stress disorder is associated with a heightened risk of dementia per se. It's just that what the triggering events of PTSD and how people manage their PTSD can put them at risk. So like, for example, there's a high correspondence of PTSD and alcoholism and substance use disorders. So if you are engaging in those substances, you're really introducing toxicity to the brain, which is going to heighten your risk. So it's those other factors. It's not just having PTSD, it's what it really means in a living circumstance that can increase your risk factor.
Okay, great. And let's see, Betty says, and I forget which presenter we had who said this, but it said a previous speaker encouraged reading first grade math and writing daily as a memory exercise. Can you comment on that?
So I don't know if you can go to a specific grade level for that, but keeping the brain active is important. And actually, we specialize our brain to do very specific things. So whether we're doing math or we're doing reading comprehension or more pure working memory exercises, the brain kind of needs all those. It's kind of a total workout in some ways. So again, anything that keeps the brain active is good. Working memory is the best. And the primary reason for that is that the brain structures that support working memory also support mood, primary memory, executive functions, all the things that you really need. So working memory exercises, if I had to choose one thing, that's the thing that I would be doing cognitively.
Okay, great. Yeah, I think in previous discussions, I know that everybody's heard of the brain training programs and exercises that are out there. And I think we've had people talk about how hey, if you like those, these can be helpful. They can't hurt you,
Right.
and they might be helpful. It's sort of, do I go to a gym? Do I go to a personal trainer? Or do I just go on a run and do sit-ups in my living room? Anything that you can do to exercise that is may be helpful. And the, it, and the Bcat the Bcat has.
Well, to your point, so there's a new program that will come out in June called 15 for Me. And some of you have heard about it because it was initially presented as a way of lowering stress for healthcare providers, basically so they can do their job. And you can find out about that on the Enrich website, enrichvisits.com as well. But you know, part of the magic of 15 for Me is that if you give yourself 15 minutes a day and you do what are called the 3 C's, so cardio, cognitive, and centered breathing, you're gonna lower stress, but you're also gonna improve your brain health, which is good. So you don't have to go to the gym for an hour every day, Steve. Just do something for 10 to 12 minutes. The important thing is consistency and sustainability. You don't have to. We're not training for the Olympics, but we are training for life. So let's do something that's going to be helpful for that. 15 for Me would be a good way of doing that.
Okay, great. All right. Well, we're basically at the top of the hour and we've gone through all the questions. Any sort of closing thoughts or things that you wanted the audience to know about that you were unable to communicate?
Just this, which is early detection really does matter. So take complaints or subjective observations very seriously. Number two, a lot of things that look like dementia are not dementia. So let's not get ahead of ourselves. There is an idea that goes something like this: suffering before it's necessary is suffering more than necessary. So that's important. And three, there is help out there, and many helpers are part of your audience. It's not just Bcat and CounterPoint. So reach out to the community. There are really skilled people who can make a difference in your life.
Excellent. And then Martha wanted you to repeat those 3 C's again.
Okay, so they're cardio, they're cognitive, and they're centered breathing. Again, use the science. So I think probably by Monday or Tuesday, there'll be more information on the Enrich Visit site about 15 for Me, if you're interested in that. And that's just going to be an app that people can just keep track of. The videos, like there's centered breathing videos that take you through it. I mean, it's very, very user friendly. So that's about brain health and lowering stress. It's not about identifying whether or not I have dementia, but you know what? What's good for the brain, if you have MCI or mild stage dementia, is also good for the brain if you have normal cognition. Start early, do it often.
Great. Okay, well, this has been absolutely amazing. I want to remind our audience that we recorded it. It'll be up at proaging.com later this afternoon. I'll make sure all the chat is there. I'll also make sure that you've got contact information for Dr. Mansbach, for Heather, and for the Positive Aging Champions that we had in the audience if you want to follow up with those folks. And again, Dr. Mansbach, thanks for
great questions. Thanks for having me. It
I
was
know.
a lot of fun. Love to do it again.
The audience really is the star of the show. The questions they ask are just so relevant, and we know that we're solving problems when we give them, decent answers to get moving in a positive direction.
Great. Sounds good. All right. Thanks, everyone.
You bet. Talk to you soon.